Hello my dear friends. So as a part of the continuation of the endocrinology series, in this session I will be discussing a very important topic, that is diabetes insipidus. So diabetes insipidus, first of all you should know what exactly is the definition of it. So it is a clinical condition which is characterized by deficiency of antidiuretic hormone, or resistance to the action of antidiuretic hormone. Right, so that is what exactly you mean by this word diabetes insipidus. Now, what should be the decrease of antidiuretic hormone to call it as diabetes insipidus? A decrease of 75% or more in the secretion of antidiuretic hormone, that will result in diabetes insipidus. So, how much should be the decrease? Decrease in more than or equal to 75% age of secretion of antidiuretic hormone, that will result in diabetes insipidus. And what exactly will be the important feature in diabetes insipidus? Because antidiuretic hormone is either absent or unable to show its action, the reabsorption of water does not occur. So the very important clinical feature in these patients with the diabetes insipidus will be in the form of polyuria. So polyuria is a very important clinical manifestation. And what is the definition of the polyuria? If the 24-hour urinary volume, if it exceeds more than 3 liters per 24 hours, then we use the terminology called polyuria. So it should be more than 3 liters per 24 hours. Or this polyuria can also be termed as when the urine output is almost 40 to 50 ml per kg. Right, when the urine output is nearly, if it is exceeding 40 to 50 ml per kg body weight, then also we use the terminology called polyuria. Now, until now I have just taught you only the definition, but let me just give you a brief introduction of the antidiuretic hormone. See, antidiuretic hormone, it is also called as the vasopressin. Now this antidiuretic hormone or vasopressin, where is it released from? It is released from posterior pituitary. So posterior pituitary gland will only act as the storage organ for the antidiuretic hormone. But where is it synthesized? The antidiuretic hormone, it is synthesized in the hypothalamus. Right, it is synthesized in the hypothalamus and it is released from the posterior pituitary gland, where it will be acting as a storage gland for your antidiuretic hormone. Now, the other important point is the action of the vasopressin and the regulation of the vasopressin. So for that you should understand the basic physiology of vasopressin. Vasopressin will go and act on the vasopressin receptors. Now, how many types of the vasopressin receptors do we have? The vasopressin receptors, we have 3 types. V1, V2 and as well as V3 receptors. Now, you take V1 receptors. V1 receptors, they are located on the blood vessels. Whereas the V2 receptors, they are present on the collecting ducts of the kidney, right, the collecting ducts of the kidney. And second thing is the V2 receptors, they are also present on the endothelial cells of the blood vessels. Right, on the endothelial cells of the blood vessels. whereas V3 receptors, they are present on the anterior pituitary. Right, so this is the distribution of the vasopressin receptors. Now, when the V1 receptors which are present on the blood vessels, if they are like stimulated, what will be the response? Please remember, when the V1 receptors which are present on the blood vessels are stimulated, there will be vasoconstriction. Right, there will be vasoconstriction. Now, where is this particular principle of vasoconstriction being used? So, why is this antidiuretic hormone called vasopressin? Because it will cause vasoconstriction. That is the reason why it is called the vasopressin. Now, the vasoconstrictor action, it is used in the treatment of esophageal varices, so these particular esophageal varices, it can develop secondary to cirrhosis of liver. And this particular vasoconstrictor action, it is also used in the treatment of shock or hypotension. Right, it is used in the treatment of shock or hypotension. So that is where the vasoconstrictor action of V1 receptor is useful. Then you take V2 receptor. See, V2 receptors, they are present on the collecting duct, and antidiuretic hormone, by acting on collecting duct, it helps in the reabsorption of water. Right, it helps in the reabsorption of water. That is one point. And by acting on the endothelial cells, what does this particular V2 receptor do? V2 receptors which are present on endothelial cells, once they are being stimulated, there will be release of factor 8, and there will be also release of von Willebrand factor. Right, there will be also release of the von Willebrand factor. Now, by your V2 receptor action, what will be the clinical use? Let me explain you. See, V2 receptor action, it is used in the treatment of diabetes insipidus, and V2 receptor action, it is used in the treatment of nocturnal enuresis in children. Right? And the V2 receptor action, it is also in the endothelial cells. So it is used in the treatment of von Willebrand disease. Right, it is used in the treatment of the von Willebrand disease, and also used in the treatment of the hemophilia. So that is about the V2 receptor action. Then followed by that, the V3 receptor action. So by acting on V3 receptors which are present on the anterior pituitary, it will cause the release of ACTH. Right, it will cause the release of the ACTH. So this is about your vasopressin receptor action. So to summarize this, we have V1, V2 and V3 receptors. V1 receptor action required for vasoconstriction. V2 receptor action required for antidiuresis and release of factor 8 and von Willebrand factor. And V3 receptor action, it is required for the release of adrenocorticotrophic hormone. Now, until now what we have discussed is the receptor action. Now you should know the regulation of antidiuretic hormone secretion. What is the factor which will regulate the ADH secretion? Let me discuss that. So, if you take the factors regulating ADH secretion. The very important factor regulating the ADH secretion is the serum osmolality. Right, it is nothing but serum osmolality. So please remember this very important point, that when the serum osmolality is increased, there will be activation of the osmoreceptors. Right, there will be activation of the osmoreceptors. Now, once these particular osmoreceptors are activated, what will be the consequence? Please remember, the osmoreceptors, where are they present? They are present within the hypothalamus. Right, the osmoreceptors, they are present in the hypothalamus. Whenever there is increase in serum osmolality, there will be activation of the osmoreceptors which are present within the hypothalamus. And whenever these osmoreceptors are activated, there will be stimulation of the thirst center, right, and there will be also release of or synthesis of antidiuretic hormone within the hypothalamus. That is what is being done whenever there is increase in serum osmolality, and it is a compensatory mechanism. You see here, whenever there is stimulation of the thirst center, the individual will try to consume the water, and whenever the ADH is being released, there will be reabsorption of water. Right, there will be reabsorption of water. So because of the water consumption and because of reabsorption of water, what will happen to your serum osmolality subsequently? The serum osmolality, it will get reduced or it will become normalized. So that is how the regulation of the ADH secretion occurs. So very simple rule is that the ADH secretion increases whenever there is increase in your serum osmolality. That is an important point that you need to remember. Now, the next important thing regarding diabetes insipidus you should know is the types of diabetes insipidus. You just see this question, like we have nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus refers to ADH deficiency, insulin insensitivity, renal tubular unresponsiveness to your antidiuretic hormone, increased renal reabsorption of salt and water. Now, there are two important forms of diabetes insipidus, out of which one is your nephrogenic diabetes insipidus. I will discuss the two forms and then I will come back to this question once again. So, if you take the types of diabetes insipidus, we have one central diabetes insipidus and the other one is nephrogenic diabetes insipidus. Right, central and as well as nephrogenic diabetes insipidus. Now, what do you understand by the word central diabetes insipidus? This is also called neurogenic diabetes insipidus. Right, this is also called neurogenic diabetes insipidus. So, in these individuals, the levels of ADH are low. Right, there are low levels of the antidiuretic hormone. Okay, so in case of the central or neurogenic, the pathology is in the center, that is either in the hypothalamus or in the pituitary gland or within the hypothalamo-hypophyseal tract. In contrast, you take your nephrogenic diabetes insipidus. In nephrogenic diabetes insipidus, the antidiuretic hormone, it is present in adequate quantities. Right, it is present in adequate quantities. There is no decrease in your antidiuretic hormone in nephrogenic diabetes insipidus. Then what is the problem here? In case of nephrogenic diabetes insipidus, there is resistance at the action of, right, resistance to the action of antidiuretic hormone. See, that is what is your nephrogenic diabetes insipidus. Right, in nephrogenic diabetes insipidus, ADH is present in adequate quantities, but there is resistance to the action of antidiuretic hormone at the level of collecting duct. Okay, so if you see this question now, nephrogenic diabetes insipidus refers to what? It refers to renal tubular unresponsiveness to your antidiuretic hormone. But whereas if you take the first option ADH deficiency, this is nothing but your central or neurogenic diabetes insipidus. Right, central or neurogenic diabetes insipidus. You take insulin insensitivity. Insulin insensitivity, this is your type 2 diabetes mellitus. Right, this is your type 2 diabetes mellitus. Okay. Now, after having discussed about the forms of diabetes insipidus, we have two more forms like which I will discuss in the etiology part, that is primary and as well as secondary diabetes insipidus also, right, where I will discuss when I discuss the etiology subsequently. But before that, let me explain you what will be the clinical features in patients with the diabetes insipidus. So you see this question here. Choose the best lab value for a patient with central diabetes insipidus. On the left hand side you have urine osmolality and on the right hand side you have the serum osmolality. So the options are 50 bar 300, 500 bar 260, 50 bar 260, 500 bar 100. Now what is the answer? First of all, let me discuss the entire concept and then I will come back to this question later. So now you should know the clinical features. Accordingly, I can crack that particular question as well. In diabetes insipidus, either there is complete absence of antidiuretic hormone or there is resistance to the action of antidiuretic hormone. So thereby what will happen? The reabsorption of water does not occur. Right, reabsorption of water is absent. So when the reabsorption of water is absent, the individual will suffer with what is called polyuria. Right, the individual will suffer with what is called polyuria because the reabsorption is not taking place at the level of the collecting duct. So water is excreted out in the form of urine and that will result in polyuria. Now whenever there is polyuria, when the large quantity of the water is getting excreted out in the form of urine, what will happen to serum osmolality? The serum osmolality will be increased. When serum osmolality is increased, what will happen? There will be stimulation of the thirst center. Right, there will be stimulation of the thirst center. So once there is stimulation of the thirst center, right, once there is stimulation of the thirst center, the individual will have polydipsia. Right, the individual will have polydipsia. So the individual will have polyuria and then the polydipsia. So polydipsia is mainly because of the excessive stimulation of the thirst center. Okay, right. Now apart from that, because of the polyuria, what will happen to urine osmolality? Urine osmolality will be reduced. Right, because of polyuria there will be decrease in the urine osmolality. So these are the features like what you will have in diabetes insipidus. Number one, water is not reabsorbed, so there is polyuria. Because there is polyuria, there is decrease in serum osmolality, increase in serum osmolality. Right, decrease in urine osmolality and increase in serum osmolality. And because of increase in serum osmolality, there will be activation of the thirst center and that is the reason why the individual is having polyuria. These are the exact features. But now, in order to crack the previous question which was of numerical value, you should know what is a normal urine osmolality and what is a normal serum osmolality. You take the normal serum osmolality. Normal serum osmolality is 285 to 295 milliosmoles. Right, 285 to 295 milliosmoles is the normal serum osmolality. And you take the normal urine osmolality. Normal urine osmolality is around 300 to 1000 milliosmoles. Right, 300 to 1000 milliosmoles. So now what will happen in diabetes insipidus? In diabetes insipidus, the serum osmolality should increase. That means it should be more than 295. And what should happen to urine osmolality? Urine osmolality should decrease. That means it should be less than 300. Now, with the same concept, we will go back to that question what we were discussing now. Right, you see, choose the best lab value for a patient with central diabetes insipidus. So if you go through the options, like if you take the decreased urine osmolality which we see in diabetes insipidus, we have two options. Option A and as well as the option B. Right, but among which particular options of your A and C, like the serum osmolality is increased, that is in your A. Okay, so 50/300 is the correct answer to this particular question. Okay, now after having discussed about the features of diabetes insipidus, let me discuss the etiology of diabetes insipidus. So I'll just show you a question. All of the following conditions are known to cause diabetes insipidus except multiple sclerosis, head injury, histiocytosis, viral encephalitis. Now, in the etiology point of view, you should understand that diabetes insipidus, first of all, it is of two forms. One we have central diabetes insipidus, and the other we have, that is, nephrogenic diabetes insipidus. And for central diabetes insipidus to occur or to develop, there could be acquired causes and there could be even genetic causes as well for the development of central diabetes insipidus. And in the similar manner, you take the nephrogenic diabetes insipidus. For nephrogenic diabetes insipidus to occur also, there are acquired causes and there are genetic causes for diabetes insipidus. Right, acquired causes and as well as genetic causes. So both of them you have. Now let me take up the acquired causes for central. Right, acquired causes for central. So central, it is also called neurogenic diabetes insipidus, or we also call it as the pituitary form of diabetes insipidus. Now let me explain you what are the acquired causes. First and foremost, the head injury, very important. So any head injury, either it is the closed head injury or the penetrating head trauma, where or when the injury is to your hypothalamus, or the injury is to your hypothalamo-hypophyseal tract, or if the injury is to your pituitary gland, that will result in the pituitary form of diabetes insipidus. Then you take the neoplasms. Neoplasms which will cause central diabetes insipidus is craniopharyngioma, so craniopharyngioma, it is a tumor which is originating from the rat case pouch, okay, that can cause the central diabetes insipidus. And the next one is the pituitary adenoma. Next, then followed by that the granulomas. Right, then followed by that the granulomas. So if you take the granuloma, what do you understand by the word granuloma? Where there is infiltration of the giant cells. Giant cells are nothing but the fused macrophages. Like for example, you take in patients with neurosarcoidosis, right, neurosarcoidosis, and then histiocytosis. So these are your granulomatous condition. So in neurosarcoidosis, there will be infiltration of non-caseating granuloma. And you take in case of the histiocytosis, there will be, it is a disorder associated with the immune system where there will be infiltration of the macrophages. So that is what is your granulomas. Okay. Next, you take the vascular condition. So in case of vascular condition, we have what is called Sheehan syndrome. See, in Sheehan syndrome, what exactly is this? Let me explain you. Sheehan syndrome, it is postpartum hypopituitarism. And this postpartum hypopituitarism, it is secondary to postpartum hemorrhage. Right, secondary to postpartum hemorrhage. So at the time of delivery or during the time of labor, if there is excess blood loss, the individual will land up in the hypotension and shock. And whenever the individual lands up in hypotension and shock, cerebral perfusion will be reduced, and at the same time, perfusion to the pituitary gland can be reduced, and that will result in postpartum hypopituitarism, which is called Sheehan syndrome. And whenever there is hypopituitarism, the posterior pituitary could have been damaged, that results in decreased release of antidiuretic hormone, resulting in central diabetes insipidus. Then you take the infections which will be causing central diabetes insipidus. We have chronic meningitis, and second we have viral encephalitis. So these are the infections which will cause the central diabetes insipidus. So these are your acquired causes for central diabetes insipidus. Now, after having discussed about the acquired causes for central diabetes insipidus, let me discuss what are the genetic causes for central diabetes insipidus. The genetic causes for central diabetes insipidus, it include either it is autosomal dominant type of inheritance or autosomal recessive type of inheritance. Now you take either of it, either you take autosomal dominant or you take autosomal recessive form of inheritance. In either of this, the gene which is being mutated is arginine vasopressin neurophysin gene. Right, arginine vasopressin neurophysin gene. So this particular gene, that is arginine vasopressin neurophysin gene, is the one which is required for the synthesis of antidiuretic hormone. If there is mutation in this particular gene, then the synthesis of antidiuretic hormone will be reduced. Okay, so autosomal dominant and as well as the autosomal recessive. Then followed by that, let me discuss the etiology of nephrogenic diabetes insipidus. In nephrogenic diabetes insipidus also we have acquired causes and then the genetic causes. You take the acquired causes for nephrogenic diabetes insipidus. First and foremost, the very important thing is drugs. And the drugs include lithium. Right, drugs include the lithium. So lithium is one of the very important drug which is used in the treatment of the bipolar disorders. Okay. Next, this can cause nephrogenic diabetes insipidus. Next, the very important drug is demiclocycline. So, if you take this demiclocycline is a tetracycline group of antibiotic used in the treatment of nephrogenic diabetes insipidus. Next, we have another important drug called methoxyflurane. Methoxyflurane, please remember, it is an inhalational anesthetic drug which can cause nephrogenic diabetes insipidus. Next, we have amphotericin B. Amphotericin B, it is an antifungal drug. This can cause nephrogenic diabetes insipidus. And we have aminoglycosides. Now what are these aminoglycosides? Aminoglycosides, they are the antibiotics used in the treatment of gram-negative infection. They can cause nephrogenic diabetes insipidus. And lastly, we have cisplatin. So cisplatin, it is an anti-neoplastic drug, right, which can cause nephrogenic diabetes insipidus. So these are the group of drugs which can cause nephrogenic diabetes insipidus. Then we have metabolic conditions. What are these metabolic conditions? They include hypercalcemia and as well as the hypercalciuria. Right, hypercalcemia and as well as the hypercalciuria. See, in case of hypercalcemia and as well as hypercalciuria, what will happen? Because of increase in the calcium levels within the body, the calcium, it gets infiltrated into the collecting duct and thereby the antidiuretic hormone, it will show or it will have resistance to its action because of the accumulation of the calcium within the collecting duct. Next, you take the infiltrative disorders. The infiltrative disorders, they include amyloidosis. Now, in case of amyloidosis, what will happen? Amyloidosis is a condition where there is abnormal accumulation of abnormal protein. So, when abnormal protein is accumulated within the collecting duct, what will happen? There will be resistance to the action of antidiuretic hormone at the level of collecting duct, resulting in nephrogenic diabetes insipidus. Then, vascular conditions, if you see, that is sickle cell anemia. Okay, so these are the acquired causes for nephrogenic diabetes insipidus. Then followed by this acquired causes, you should know what are the genetic causes for the nephrogenic diabetes insipidus. You take the genetic causes. We have the following forms. Number 1, X-linked recessive. Second, we have autosomal dominant, and then we have autosomal recessive. You take X-linked recessive. X-linked recessive, the gene which is being mutated is arginine vasopressin receptor 2 gene. Right, arginine vasopressin receptor 2 gene. See, this arginine vasopressin receptor 2 gene, once it is being mutated, the action of the antidiuretic hormone does not occur at the level of collecting duct, and that can be inherited as the X-linked recessive. Then you take autosomal dominant or the autosomal recessive. In autosomal dominant or autosomal recessive, like the gene which gets mutated is the aquaporin 2 gene. Right, aquaporin 2 gene mutation, see, it is your aquaporin channels like AQP1 and as well as AQP2. Through this particular AQP2 channels, which is formed at the level of the collecting duct, right, which is formed at the level of collecting duct, the water will be reabsorbed. Now, when there is mutation in this aquaporin 2 gene, the aquaporin 2 channels are not formed. And even though antidiuretic hormone is there, the water reabsorption at the level of the collecting duct does not occur. And that aquaporin 2 gene mutation, it can be either autosomal dominant or the autosomal recessive. Right? It can be inherited as autosomal dominant or autosomal recessive. Now, we have one rare form of autosomal recessive genetic disorder. Now, what is that particular rare form of autosomal recessive genetic disorder? That is the Wolfram syndrome. The Wolfram syndrome, this is also called Didmore syndrome. Right, this is also called Didmore syndrome. Now, what does this Didmore stands for? The word DI stands for diabetes insipidus. The word DM stands for diabetes mellitus. The word OA stands for optic atrophy. The word D stands for deafness. Right, the word D stands for deafness. So, these are the components of the Didmore syndrome. And remember, this Didmore syndrome, it is one of the rare autosomal recessive genetic disorder. Right, autosomal recessive genetic disorder. Now, in this particular Wolfram syndrome, which is also called Didmore syndrome, it is mainly due to mutation of a gene called WFS1 gene. Now, where is this particular gene located? So, if you see this gene, it's an X-linked recessive form. It is on XQ28. That has been described. The causative has not yet been identified. So, that particular gene, that is WFS1, it is present on XQ28. So, now going back to the question which we were discussing about the etiology, all of the following are known to cause diabetes insipidus except your multiple sclerosis. Head injury can cause central diabetes insipidus. Histiocytosis, it is a granulomatous condition which can cause central diabetes insipidus. Viral encephalitis, it is an infection which can cause the central diabetes insipidus. Now, apart from this central and nephrogenic, we have one more form of diabetes insipidus called gestational diabetes insipidus. Until now, you might have heard about the terminology called gestational diabetes mellitus, but we also have a terminology called gestational diabetes insipidus. So here, there is primarily deficiency of the arginine vasopressin. right? Primarily, there is deficiency of arginine vasopressin. Now, why does this gestational diabetes insipidus occurs? Why there is deficiency of plasma AVP? This can result from increased metabolism by an N-terminal aminopeptidase produced by the placenta. So placenta, it produces an aminopeptidase. And what is the name of that particular aminopeptidase? That is N-terminal aminopeptidase. Right, that is your N-terminal aminopeptidase. Now this N-terminal aminopeptidase, what it will do is, it will cause increased metabolism of right, it will cause increased metabolism of the arginine vasopressin. Now, because of increased metabolism of arginine vasopressin, there will be decreased levels of the AVP. And why is this increased metabolism? Because of the production of N-terminal aminopeptidase by the placenta, which is formed during the pregnancy. So this is referred to as gestational diabetes insipidus because the signs and symptoms manifest during pregnancy and usually they remit several weeks after the delivery. So after the delivery, this gestational diabetes insipidus will return back to normal. So this is your primary deficiency of plasma arginine vasopressin. There can be also secondary deficiency of the arginine vasopressin secretion. And that secondary deficiencies of arginine vasopressin secretion, it results from inhibition by excessive intake of fluids. When the individual is consuming excess amount of fluids, what will happen to your AVP secretion? The AVP secretion decreases. That is called as secondary deficiencies of AVP secretion. Now, these are referred to as the primary polydipsias. In the sense, like why is that secondary deficiency of arginine vasopressin secretion? Because of excessive intake of the fluids, right? Because of excessive intake of fluids. And that excess intake of fluid, which we call it as the primary polydipsias, right? This we call it as primary polydipsias. And this can be divided into three categories. What are those three categories? Number one, Dipsogenic diabetes insipidus. Number two, psychogenic polydipsia. Number three, iatrogenic polydipsia. Now, what is this dipsogenic diabetes insipidus? Dipsogenic diabetes insipidus, it is a form of primary polydipsia where there is excessive thirst within the individual. Right? It is characterized by inappropriate thirst caused by reduction in the set of the osmoregulatory mechanism. Now, what are the conditions where there is inappropriate thirst? What are the conditions where there is reduction in the set of osmoregulatory mechanisms? It is associated with multifocal diseases of the brain. Now, what are those multifocal diseases of the brain? Such as neurosarcoidosis, right? Such as neurosarcoidosis. Next, tubercular meningitis, then multiple sclerosis. So these are the conditions where you have the development of the dipsogenic diabetes insipidus. Next, we have psychogenic polydipsia. See, the second subtype of the secondary deficiencies of the AVP, it is psychogenic polydipsia. It is not associated with thirst. And here, the polydipsia seem to be a feature of psychosis. Right? The polydipsia, it is secondary to psychosis. So when the individual is consuming excess amount of water because of some psychological problem or because of some obsessive compulsive disorder, what will happen? Very simple. When there is more polydipsia, there will be decrease in serum osmolality. When there is decrease in serum osmolality, there will be decrease in your arginine vasopressin secretion. That is your second subtype. And the third important subtype is your iatrogenic polydipsia. See, iatrogenic polydipsia, it results from recommendations to increase the fluid intake from its presumed health benefits. Okay, so because of some health benefits, if the individual is consuming excess amount of water, that will result in decrease in serum osmolality, and this decrease in serum osmolality will decrease the AVP release, and that will result in deficiency of arginine vasopressin. Okay, your gestational diabetes insipidus is a primary deficiency. That is, your N-terminal aminopeptidase produced by the placenta will increase the metabolism of arginine vasopressin, and that will decrease the levels of AVP. And the next important is secondary deficiencies. Secondary deficiencies of arginine vasopressin, it could be dipsogenic diabetes insipidus, it could be psychogenic polydipsia, or it could be iatrogenic polydipsia, right? Dipsogenic diabetes insipidus, because of some underlying pathology like neurosarcoidosis, tubercular meningitis, multiple sclerosis, there will be inappropriate thirst. Psychogenic polydipsia, because of some psychosis or obsessive compulsive disorder, there will be excessive consumption of water. Iatrogenic polydipsia, because of some health benefits, the individual will consume excess amount of water, and that will decrease the serum osmolality. Now I'll just show you one question. We have a 33-year-old lady presents with polydipsia and as well as the polyuria. Her symptoms started soon after a road traffic accident 6 months ago. The blood pressure is 120 by 80 millimeters of mercury, and there is no postural drop. The daily urine output is 6 to 8 liters. The investigations showed sodium 130, potassium 3.5, urea 15, sugar 65, plasma osmolality 268, urine osmolality 45. What is the most likely diagnosis in this individual? The options given to you are central diabetes insipidus, nephrogenic diabetes insipidus, resolving acute tubular necrosis, psychogenic polydipsia. Now, many of you might be under the impression the answer to be diabetes insipidus, but please remember, the answer is not diabetes insipidus, the answer is psychogenic polydipsia. Right. See, always after a road traffic accident, it need not be like central diabetes insipidus. And always remember, road traffic accident means always it is not your head injury. Okay, just by seeing the road traffic accident, just by seeing the terminologies like polydipsia and polyuria, don't jump onto the answer of diabetes insipidus. You just analyze your laboratory results also. Now, what are the laboratory results which are going against your diabetes insipidus? That is your plasma osmolality. In diabetes insipidus, what did I tell you? The plasma osmolality should be increased. Right, the plasma osmolality should be on the higher side. That is what we have discussed in diabetes insipidus. But 268 milliosmoles, what is that? It is decreased serum osmolality. So, in this patient, there is decrease in serum osmolality. And not only that, there is also decrease in the urine osmolality. Right, there is decrease in serum osmolality and there is decrease in urine osmolality. So where do you have that? You will have that in patients with the psychogenic polydipsia. Now why is that? Why in case of psychogenic polydipsia you will have both of them being reduced? Let me explain you. See, in psychogenic polydipsia, it occurs secondary to obsessive compulsive disorder, or it occurs secondary to your psychosis, where the individual is consuming excess amount of water. When the individual consumes excess amount of water, what will happen to serum osmolality? That will be decreased. When the serum osmolality is decreased, subsequently there will be decrease in the ADH production. When there is decrease in ADH production, there will be increase in the urine output because the water reabsorption does not occur. And thereby, what will happen to your urine osmolality? Urine osmolality will reduce. So, in psychogenic polydipsia, serum osmolality is reduced and as well as the urine osmolality is also reduced. That is what will happen in psychogenic polydipsia. Now, I'll just give you the three important scenarios. A patient has presented to me with a history of polyuria. Right? Now, when I have tested the serum osmolality and as well as urine osmolality, I got three clinical scenarios. In one scenario, I got serum osmolality being increased and urine osmolality being decreased. This is one scenario I got. And the second scenario, the serum osmolality is reduced and even the urine osmolality is also reduced. This is another scenario. And the third important scenario is the serum osmolality, either it is normal or increased, and urine osmolality, it is increased. Okay, so these three are the different scenarios with me now, with the history of polyuria. Now I should be able to make out like what are these three clinical scenarios. So if you take the first one, increase in serum osmolality, decrease in urine osmolality. That is what is the current disorder what we are discussing now. That is diabetes insipidus. So in diabetes insipidus, please remember the serum osmolality is increased and urine osmolality is decreased. And you take the second scenario, that is decrease in serum and decrease in urine osmolality. Just now we have discussed, that is the psychogenic polydipsia. So in psychogenic polydipsia, you will have decrease in serum osmolality and decrease in urine osmolality. And where will you have this third scenario? Urine osmolality is increased, like it is more than 300, with serum osmolality being normal. You can have that in patients with the diabetes mellitus. In diabetes mellitus, why do you think that the urine osmolality is increased? Because in diabetes mellitus, there will be glucosuria. And because of the presence of the glucose within the urine, there will be increase in urine osmolality to more than 300 milliosmoles. Okay. So this is how the differential diagnosis of the polyuria can be made out. Now, I'll just show you one more one more question. Yes, you see this is a multiple choice question. Which of the following statements about diabetes insipidus is true? First option, urine osmolality should be more than 300 milliosmoles. Second option, plasma osmolality should be less than 280 millimoles per liter. And third option, water deprivation test is required. And fourth option, urine osmolality is more compared to that of the plasma osmolality. So the answer to this question is water deprivation test is required. So please remember, water deprivation test, it is considered as the investigation of choice. Right, it is considered as the investigation of choice. You take urine osmolality in diabetes insipidus. What will happen? The urine osmolality will be decreased. Right? It should be less than 300 milliosmoles. Now, in diabetes insipidus, what should happen to plasma osmolality? The plasma osmolality should be increased. It should be more than 300 milliosmoles. And you take the fourth option. What should be more? Plasma osmolality should be more than compared to that of the urine osmolality. Right? Plasma osmolality should be more than compared to that of the urine osmolality. So that is what you will have in patients with the diabetes insipidus. Now, in which group of individuals we do this particular water deprivation test? Please remember, water deprivation test is indicated in patients with hypotonic polyuria. So in those individuals where there is presence of hypotonic polyuria, like we do this water deprivation test, in the sense the urine osmolality should be less than 300 milliosmoles. Now, what is the purpose of doing this particular water deprivation test? The purpose of this water deprivation test is to differentiate psychogenic polydipsia right, to differentiate psychogenic polydipsia from diabetes insipidus, right? That is the purpose of doing this water deprivation test. Now let me also explain you like how we do this water deprivation test. Now, for suppose a patient is presenting to you with the history of polyuria and you have tested, right? You have tested the urine osmolality. The urine osmolality, you found that it is less than 300 milliosmoles. Then what we need to do in this individual is we need to first restrict the water intake for 4 to 6 hours. Right, you need to restrict the water intake. So restricting the water intake is nothing but your water deprivation, right? Now following that, you should do or you should test for the urine osmolality again. After restricting the water intake for 4 to 6 hours, test for urine osmolality once again. Now for suppose, right, I got a scenario where urine osmolality is increased, right? I got a scenario where the urine osmolality is increased, but if you take the plasma osmolality is within the normal limit, then this particular scenario I will consider it as psychogenic polydipsia or a normal individual, right? Normal individual or psychogenic polydipsia. Right, normal individual or psychogenic polydipsia, where if you take the urine osmolality by plasma osmolality ratio, it will be more than 2. Right, urine by the plasma osmolality ratio will be more than 2. Now why does this happen, I will explain you. But for now just remember, after restricting the water intake, if you test the urine osmolality after 4 to 6 hours, if the urine osmolality is increased, then it is normal or psychogenic polydipsia. In other way around, you take the other scenario. If the urine osmolality, right, urine osmolality is still on the lower side, urine osmolality is still on the lower side, and plasma osmolality is increased, right? Plasma osmolality is increased, and if you take the U by P ratio, if it is less than 2, then this is suggestive of diabetes insipidus. Right? This is suggestive of diabetes insipidus. Now, what is the concept behind this? Let me explain you. Very simple concept. You take in a psychogenic polydipsia patient or in a normal individual, as such, there is no decrease in antidiuretic hormone. In psychogenic polydipsia, because of some psychological issue, the individual is consuming excess amount of water, and that is the reason why the individual will excrete excess amount of urine. So, urine osmolality will be reduced. But in the same patient with psychogenic polydipsia, if you restrict the water intake, right, if you restrict the water intake, what will happen? Immediately, these patients with psychogenic polydipsia, once you restrict the water intake, the serum osmolality increases, and once the serum osmolality increases, the urine osmolality also increases. That is what will happen in psychogenic polydipsia. U by P ratio will be more than 2. Whereas, you take in case of the diabetes insipidus, even though you restrict the water intake, there is no ADH production, right? There is no antidiuretic hormone action or there is no ADH production. So subsequently, what will happen in those individuals? When there is diabetes insipidus, even though you restrict the water intake, there is no ADH production. So that is the reason why water will be continuously getting excreted out in the form of urine. The urine osmolality will be still on the lower side. So after water deprivation, if urine osmolality increases, psychogenic polydipsia. If the urine osmolality is still on the lower side, then it is your diabetes insipidus. Now, how will you further differentiate? Right? How will you further differentiate? Now, from your water deprivation test, you have come to a conclusion that you are able to differentiate psychogenic polydipsia and as well as diabetes insipidus. Now, this patient, I want to know whether he is suffering with central diabetes insipidus or the nephrogenic diabetes insipidus. Now, to this patient, I will give exogenous ADH. So, if I give exogenous ADH for suppose, if the urine osmolality is increased, then it is your central diabetes insipidus. For suppose, if urine osmolality is still on the lower side even by giving exogenous ADH, then this is your nephrogenic diabetes insipidus. Right, then it is your nephrogenic diabetes insipidus. This is what is the application of water deprivation test. And remember, water deprivation test is considered as the investigation of choice in patients with the diabetes insipidus. This helps in differentiating psychogenic, central and as well as nephrogenic diabetes insipidus. Now, after having discussed about the investigation, let me discuss the treatment in patients with the diabetes insipidus. So regarding the treatment, you see this question here. Which of the following is the drug of choice for central diabetes insipidus? Desmopressin, demiclocycline, thiazide diuretics, lithium. Remember, desmopressin is considered as drug of choice for central diabetes insipidus. See, in case of central diabetes insipidus, the primary problem is deficiency of antidiuretic hormone. So, you need to give antidiuretic hormone or you need to give ADH analog for the treatment of central diabetes insipidus. So, desmopressin, it is a vasopressin analog. Right, this action of desmopressin is on V2 receptors. Right, it is exclusively on V2 receptors. Whereas you take vasopressin. See, differences between vasopressin and as well as vasopressin analog desmopressin. Vasopressin, it has non-selective action. It will act on V1 and as well as the V2 receptors. Desmopressin, it selectively acts on V2 receptors. Right, it selectively acts on V2 receptors. And vasopressin, it has short half-life, whereas desmopressin, it has long half-life. Right, desmopressin, it has long half-life. So these are the differences between the vasopressin and desmopressin. And what we give is vasopressin analog, that is desmopressin we give. Now, you take this desmopressin. What are the various routes of administration and what are the doses of this particular desmopressin? Let me explain you. This desmopressin, it can be given through oral route, right? It can be given through intranasal. It can be given through subcutaneous. And it can also be given through the intravenous route of administration. Okay. Now, you let me discuss the dose now. You take the intranasal. The intranasal, you have to give 10 to 40 micrograms per day. Right, 10 to 40 micrograms per day. And whenever you are giving this desmopressin intranasal route, the adverse effect is that the individual will develop nasal irritation and rhinitis. Right, nasal irritation and as well as the rhinitis. So these are the adverse effects associated with the intranasal route of administration. And you take per oral route. Per oral route, the dosage is 0.1 to 1.2 milligrams. This should be given twice daily or thrice daily. Twice daily or thrice daily. And you take the intravenous or subcutaneous route. The dosage is 2 to 4 micrograms per day. Okay, so these are the various routes and the respective doses given in the treatment of diabetes insipidus. And we also give the oral desmopressin. Please remember, oral desmopressin, it is also the drug of choice for nocturnal enuresis. Right, it is also the drug of choice for nocturnal enuresis. Now, you take this particular antidiuretic hormone. Once you give through the intravenous route or the subcutaneous route, the onset of antidiuretic hormone action, it is rapid, right? So the onset will be within 15 minutes. If you give through the intravenous route, the onset of action will be within 15 minutes, right? Whereas you take the oral administration, after oral administration, the onset of action is within 60 minutes. Okay, so if you want to have a quick onset of action, you can give through the intravenous route. The intravenous route, within 15 minutes, you will have the onset of action. So that is about the vasopressin analog, that is desmopressin. And we have few more vasopressin analogs. The other vasopressin analogs are lipressin, but this we don't use in the treatment of diabetes, central diabetes insipidus. Lipressin, it is longer duration of action and it has non-specific action. And you take terlipressin. Terlipressin, it is a prodrug of vasopressin, and terlipressin we use mainly in the treatment of the esophageal varices. Right, mainly we use in the treatment of esophageal varices by acting on V1 receptors. Right, and even felipressin, right, it has non-specific action. So these are all your like analogs of the vasopressin. Now, apart from the desmopressin, let me tell you, we have few more drugs, right? We have few more drugs which will enhance the action of the antidiuretic hormone. Now, what are those drugs which will enhance the action of the antidiuretic hormone? These particular drugs include, number one, chlorpropamide. What is chlorpropamide? Chlorpropamide, it is the first generation sulfonylurea. Right, it is the first generation sulfonylurea. So, it is given through oral route. It is an oral hypoglycemic agent and it enhances the renal response for antidiuretic hormone. Right, it enhances the renal response to antidiuretic hormone, and this chlorpropamide, it can lower the urine output. Right, it can reduce the urine output by as much as 50%. Right, by as much as the 50%. That is what is the advantage of this chlorpropamide. And we have another drugs, that is carbamazepine. See, the carbamazepine, it will enhance the action of the antidiuretic hormone. This is an anti-epileptic drug. Right, this is an anti-epileptic drug which is used in the treatment of the focal epilepsy. And clofebrate, it is the drug which is used in the treatment of dyslipidemia. Okay, and even this is also the drug which will enhance the action of antidiuretic hormone. So these three drugs, that is chlorpropamide, carbamazepine and clofebrate, they will enhance the action of the antidiuretic hormone. Now after having discussed about the treatment of central diabetes insipidus, you see the treatment of the nephrogenic diabetes insipidus. What is the mainstay of treatment of nephrogenic diabetes insipidus? Desmopressin. Second option, thiazide or amiloride diuretics and salt restriction. Third option, desmopressin and salt restriction. Fourth option, vasopressin and salt restriction. Please remember, the mainstay of treatment of nephrogenic diabetes insipidus is the thiazide or amiloride group of diuretics. So, the thiazide group of diuretics, that is hydrochlorothiazide, right? Hydrochlorothiazide, this is considered as the drug of choice, right? And this hydrochlorothiazide, it is given 12.5 to 25 milligrams once daily. So this is the dosage of your hydrochlorothiazide. Now you take this particular thiazide diuretics. Thiazide diuretics, remember, already they will cause diuresis. And how do you think they are useful in diabetes insipidus, that is in nephrogenic diabetes insipidus? Remember, thiazide diuretics, where is the site of action? The site of action for diuresis to occur is the distal convoluted tubule. Right? The site of action for the diuresis to occur is at the level of the distal convoluted tubule. Okay. Now, you take in diabetes insipidus, the diuresis is occurring because of pathology at the level of the collecting duct. Right? Diuresis is occurring because of pathology at the level of collecting duct in diabetes insipidus. And thiazide diuretics, if you give, the diuresis will occur because it will inhibit sodium chloride channel at the level of the DCT. So, now what these thiazide diuretics will do? Thiazide diuretics, please remember, they will cause compensatory increase in water reabsorption at the level of the proximal convoluted tubule. Right? So, this is the action of thiazide diuretics in case of the nephrogenic diabetes insipidus. And because of this particular action of thiazide diuretics at the level of PCT in nephrogenic diabetes insipidus, that is the reason why hydrochlorothiazide is considered as the drug of choice in nephrogenic diabetes insipidus. Now, after this thiazide diuretics, please remember, we have one more drug, that is amiloride. What is this amiloride? Amiloride, it is epithelial sodium channel blocker. Right? It is an epithelial sodium channel blocker. Now, this epithelial sodium channel blocker, that is amiloride, this is considered as drug of choice for lithium-induced diabetes insipidus. For lithium-induced diabetes insipidus, amiloride is considered as the drug of choice. Now, in nephrogenic diabetes insipidus, apart from giving thiazides or amilorides, salt restriction also has to be done. For suppose, in spite of giving all these drugs, if polyuria still persists, right, if polyuria still persists, then we give indomethacin. Right, then we give indomethacin. So indomethacin is added if the polyuria still persists. Okay, so this is about the treatment of the central and as well as the nephrogenic diabetes insipidus. So if you see the sequence, we have discussed all the way from basic physiology of antidiuretic hormone, then what are the forms of diabetes insipidus, what will be the clinical features, etiology, investigations and treatment of diabetes insipidus. So with this, I conclude this very important topic, that is diabetes insipidus. Thank you very much.